Hello, everyone. I'm David Lillicrap from Queen's University in Kingston in Canada, and it's my pleasure to introduce Professor Margareth Ozelo from the University of Campinas in Brazil. And Professor Ozelo and I are going to be discussing today issues concerning the diagnosis and the monitoring of therapy for hemophilia. Margaret, it's great to see you again. It was good to see you in Montreal. Did you enjoy the Congress?
Hi, David. Yeah, it's a pleasure to meet you here. Yes, ISTH 2023. I think it was great. We have the opportunity to discuss, the new developments in several areas, and including the diagnosis. I think there are new things that eventually we will hear more about that.
Yeah. So there are four areas that I'd like you to address in an informal way today. The first is in 2023, how are we diagnosing this condition? Is there anything different that we're doing now that we weren't in the past?
Well, David, as you know, the diagnosis for hemophilia is quite simple. It's based on the quantification of factor VIII or factor IX activity. And for years, we are using the two methodologies. One stage assay that is based on ATTP, that's common usually everywhere. And also we have the chromogenic assay. So these are the both assays that it's common using in everywhere, and it's not complicated. It's quite easy, but we needed to realize that even now there are some places that struggle to have this access easily. So one of the topic that we know that they are discussing quite often right now is around the development of point of care platforms. So we know that from Netherlands, Dr. Van Hart from Enzire is actually developing a new platform that is based on enzymatic activities that uses small blood volumes that in the future it will be good for the diagnosis and for treatment monitoring. We also hear from India. I know that they are developing a point of care with low cost that is more for the quality assessment. It will give us the answer yes or no, but without the quantity evaluation. This will not solve the problem, but it will help, especially in remote areas, to have access to the diagnosis. And of course, in terms of the genetic diagnosis, as you know, for genetic counseling, there are so many new technologies that have been used, and this became more easy to do and to perform as NGS and other platforms. So I think in 2023 we can better diagnose our patients and also to have more information that will be good to follow up our patients.
Yeah, thank you. So let's move on now to how we monitor therapy. So there are all sorts of we've discussed in this series different types of therapies, both substitution and non-factor replacements. So in terms of monitoring how well patients are doing on their treatments, could you give us some idea about what you're doing with those various groups of patients treated with different types of interventions?
Yes, David, this is actually important topic when we discuss about the treatment monitoring. So, of course, especially for replacement therapies, we have so different treatments available now. And each of the treatments sometimes need a specific reagents. So one thing that I realized with the group from our lab here at Unicamp, for example, is that it's very critical to have a close communication between the clinic and the lab. They need to know which treatment the patient is using to actually guarantee that this assessment, the monitoring, will be performed in the right way. This is one thing that I think is new. But we also need to know that for no replacement therapies, there are so different options that we started to use more and more. So one question is if we need to monitor this kind of no replacement therapies, and I include in here the emicizumab and the new rebalancing agents. So all this is kind of new, and we can even use different assessment as thromboelastography, thrombin generation assay. That is more for research, because in the daily basis, I think that are difficult to use this kind of assessment. I still believe that the clinical evaluation is always critical, and we also needed to add this kind of variables to decide if it's a need to change the treatment or not. And for these new drugs, we can also discuss if the new drugs concentration sometimes is helpful, and eventually, we also needed to have access to evaluate the presence of anti-drug antibodies. I think all this kind of things is quite important. Discussing about anti-drug antibodies, we cannot forget about the inhibitors. And for the inhibitor measurements, we still using Bethesda-Neiman assay, and we know that we are using this for decades, but this is actually has a very high variability and with low reproducibility. So because of that, this is also something that we know that some groups are trying to have better assessment for even inhibitors. That is very important for us, especially when we still using replacement therapies.
Thank you. That's a very helpful discussion of the things that you're doing. I'd now like to move on to how you assess short-term and long-term outcomes in hemophilia. So obviously, this is a bleeding disorder, and the first thing that we need to discuss is when patients are seen by you, how you assess acute bleeding problems, which often, of course, involve the musculoskeletal system, and then the long-term outcomes of musculoskeletal health and actually more global things, which involve the patient's lifestyle, their personal lives, their careers, and so on. So if you could give us an idea about the global assessment, acute and long-term, of this condition.
Thank you, David. This is actually a very good question. So, in terms of the acute bleeding events, for years here in our clinic, we have the privilege to have the physiotherapy the whole time. This is really, really helpful. But I think this is something that adds for the clinical evaluation. Uh, and it's not that the doctors and the other ones cannot evaluate the assessment, but of course we are learning quite a lot with that. So for years we are using more the physical evaluation, especially for the joints. But we have for more than 5 years now the use of point of care ultrasound, and this completely changed our clinic, and change also the way that I used to see my patients, because we learn quite a lot, especially how much each bleeding can interfere into joints, and to better to have a better assessment about the consequences of a single bleeding and the inflammatory presence that we can see into the joints. We're still looking forward to have biomarkers that also help us to better evaluate the acute events. But I think we didn't have enough progress related to that. In terms of the long-term evaluation, well, we have several scores, and we routinely use these in our clinic for at least annual evaluation. So for the physical assessment, we are using HAHS, the Hemophilia Joint Health Score. This is helpful, especially for the young patients, and now we also are using for all patients. And just recently it was published, the new AJHS for adults that was validated. I think this was important for the community. And we routinely use the ultrasound scores. These are the other the imaging to add the imaging to the physical assessment of the MSK is always important. But as you said, quality of life scores is really helpful also to evaluate the patients and to pay attention about what their demands and what we can do better for them. Um, it's quite interesting because I think this actually help us to be more close to our patients and sometimes give us some ideas about things that we are not very careful about. And I think we learn quite a lot with patients all the time. So I think in terms of the long term, for example, we have discussed for adults that eventually to decrease the frequency of the infusions for the factor. Well, I have listened for patients that sometimes they even prefer daily prophylaxis because it's just a kind of routine for them and they don't need to think about hemophilia the rest of the day. So all these kind of things are ideas that we needed to pay attention, listen more to our patients.
I have a question about the changes in therapy, which have been huge in the last decade. I think some patients find it quite difficult to change from their previous replacement therapies, and so their perception of whether they need to treat themselves or not is actually quite difficult. So some of these therapies now, as you well know, are given every 2 weeks or even once a month. And I think that patients probably are quite nervous during that time that they may be having bleeds, whereas some of their discomfort is probably just chronic inflammatory changes in their joints. How do you deal with that in the clinic now?
Yeah, this is actually one of the challenges, especially for the adults. And even here in Brazil, that we just started to have access to primary prophylaxis since 2010. So we still have several adolescents that have some chronic problems into their joints. So the chronic pain, the arthropathy, that they developed in the past still a challenge for us to decide if it's a new bleeding event or it's just inflammatory manifestation. And to actually to differentiate that, it's always a challenge. The imaging, the ultrasound is helping us quite a lot, especially to have the longitudinal evaluation. So it's good when we have the previous evaluation to see if something changed or not. So of course, for this new nowadays, we need to think about if we need something that's more precise. For example, MRI scan can be one alternative. In this case, we just use it for the in situations that is critical for us to evaluate a particular joint, not regularly. It's difficult for the patients. We don't have easy access for MRI scan. Um, but I think we still need to learn more and to have other perspectives. That now the things are changing, and some of the patients actually, even to decide to change the treatment or not, is not easy. Some of them, as you said, are happy the way that they have been treating over the years, and they are more confident with the treatment that they receive over the years. And we need when we have new options, it's actually quite important to discuss with them if it is a need to change or not, and how confident they are with the way that they are treating themselves.
Thank you, Margaret. Yeah, these things are really quite complicated. In some ways, complicated for good reasons, that we have now many different options. But I think the patients need to be flexible, I think, as these new things come into the clinic. So I'd like to finish by asking you a question to look forward. So current prophylactic therapy is really good for hemophilia. And there are many patients now who experience very few bleeds each year, probably less than 2 or 3 per year. And so should we be thinking of additional ways of monitoring how well we're treating them? Are there things that you would like to see on the horizon in the next 5 or so years that would help us make the treatment even better and allow us also to compare different forms of new therapies? Because the bar, the threshold for getting better is very difficult now. So I'm interested in your thoughts about this.
Yeah, I agree with you, David. I think, the outcomes that we are seeing with the new treatments and with this new area of treatment for hemophilia is improved quite a lot. So I think, well, this community already has so many scores in different ways, but I may say that eventually we need to think some of more sensitive scores for this particular situation. We have been discussed, for example, for the MSK evaluation, if the MRI scores can be helpful. I think it's difficult. It's difficult even because if the patient already have some arthropathy, it's not easy for them to stay in a steady state for minutes, or that can give them pain. But I think the ultrasound, we can work better in terms of the better scores in patients that already have, for example, some arthropathy, not only the ones that start with primary prophylaxis or pristine joints, to how this evaluate. This will be good. And I also believe that we should not give up to find good biomarkers. I think this will be a challenge, but maybe we can have, or a combination of some of the outcomes that then can be helpful. If we find some biomarkers that give us more information, it will be good. And of course, the quality of life and the patient's report outcomes is always important. So I think now the patients have more information, the access to the information is easier to obtain, and is also an opportunity for us to listen for them, and maybe some of these PROs can also be developed in this perspective of the new scenario that we have.
Yeah, it's an interesting challenge that all these new therapies have given us. And I agree with you that the holy grail is some blood biomarker that allows us to see that the joints are in good state and there's been no bleeding. But I think probably both you and I have seen over the last 10 years that various people have tried this, and we aren't there yet. That maybe we need to keep looking, because that would be ideal. And then, of course, the patient-reported outcome surveys are getting better. So I'm going to wind this up today. I really appreciate your very comprehensive and helpful comments. This is a great time for hemophilia, right? I mean, the patients have got so many choices, and we have to think hard about how we personalize these treatments. So, Margaret, thank you again. I wish you well. Stay well, and hope to see you again in the near future. And at this point, we'll finish. Thank you very much indeed, everyone.
Thank you, David. Thank you for this great conversation. I think we are always looking forward to see, the new developments. Thank you.